There are two main posterior approach ptosis surgeries, the MMCR or Müller's muscle conjunctival resection or the white line advancement. The MMCR is preferred in patients with a positive phenylephrine test, whereas the white line advancement can be performed in patients who have a negative phenylephrine test but also have moderate ptosis. This table shows why the white line advancement is preferred in mild or moderate ptosis where there is a dehiscence of the levator muscle. In this video, we will be seeing the surgery of this 64-year-old male with bilateral ptosis after a frontal block to anesthetize the eyelid. By placing a Demers retractor on the upper lid and everting it, local anesthesia is then infiltrated at the upper edge of the tarsus in the subconjunctival plane. This also helps in creating a plane for dissection. I usually prefer to put in a traction suture to help in everting the eyelid and keeping it fixed. The incision is then made all along the upper edge of the tarsus. Once this is done, dissection is carried out in the sub-Müller's muscle plane, such that you should be able to see the conjunctiva on the upper edge of the wound. Once the Müller's has been dissected off of the conjunctiva, you can dissect further with a Q-tip. Dissection is then carried out till you can see a white line. This white line represents the dehisced or the detached edge of the levator muscle. The surgery aims to reattach this white line to the upper edge of the tarsus. A double-armed suture is used, as in this case an absorbable 6O polygalactin or vicryl suture is used. One arm is passed through the white line or the levator and then through the upper edge of the tarsus, where then it is exteriorized through the lid crease which has been previously marked. The same process is then followed for the other arm of the suture, passing through the edge of the white line and then through the tarsus and then again exteriorized. This suture after exteriorization can be tied over a bolster or can be directly tied. This surgery also does allow for some intra-op adjustment based on the appearance of the height by asking the patient to open their eyes. Some surgeons may also prefer to use a non-absorbable suture such that post-op inflammation is less. Now, based on the eyelid contour and the severity of the ptosis, 2 or 3 such sutures can be passed. In patients with a significant medial droop, it is advisable to pass one suture extremely medially to make sure that the medial droop is then addressed. In this case, 2 sutures were adequate to reattach the levator to the tarsus. I prefer to keep a bandage contact lens in place for about a week to 10 days, after which the sutures are removed. This gentleman at 2 weeks post-op showed adequate correction of the lid height and contour with no lag of thalamus post-operatively. Thank you.